Good evening to all here in the Bahamas and those who may be joining us worldwide and internationally. It's a pleasure again to be back in studio to discuss with some of my other colleagues a very important topic that affects us all, especially here in the Bahamas. And so I want to welcome those who will be joining us and to say it's always a pleasure to have our viewing audience because they continue to support us, for which we are grateful. This week is considered Glaucoma Awareness Week. And because of that, we decided to host another vision forum by the Optometric Association of the Bahamas. And the Optometric Association of the Bahamas is an organization here, comprises optometrists, and it is our duty and goal to enlighten, to educate, and to give our people and those who are elsewhere information about the importance of vision, eye health care, and also medical conditions that relate and can affect your vision and your eyes. And so this week is recognized as Glaucoma Awareness Week. And as a result of that, we decided that we would come on again to educate and to share and give information concerning glaucoma, because it's a disease that impacts us here in our country and around the world. And it's very significant in the Black population, which we comprise, and not just the Black population, but also in the Haitian population. So the Haitian Bahamian population and the indigenous Haitian population. So it's a very prevalent disease, and we decided that we would give information and we will take your questions. You can just text or write them to us, and we would be more than happy to answer your questions. Now I'm waiting for my two special guests. They're both running late, and they should be signing on soon. However, before they come in, just want to say that the show is being broadcast live via Palmdale Vision Center, our Facebook page, and also on YouTube. And that is where you can also reach us. My two other colleagues will be from two other eye care practices, and once they sign in, we will just introduce them and then we will start our discussion. Glaucoma is a very insidious disease, meaning that you probably won't know you have it unless you check your eye care professional. And not just ophthalmology, but optometry. We as optometrists are very involved in diagnosing this particular condition. And many of us follow patients continuously who have the disease. So listen in this evening, you should get some valid information. And if you have any questions, you can just send them to us via the text or comment section on Facebook or YouTube. I want to say welcome, and hopefully our guests should be signing in soon, unless they want me to really talk about it. And I don't wish to do that for the entire evening, but if I have to, I would. But I'm waiting for them. Anita, use your phone if you have to. Use your phone, Anita. Mm-hmm. We have one guest in, Dr. Anita Brown-Dean, and we're waiting for that final guest. And so, Dr. Dane, good evening and welcome to the studio. How are you?
I am wonderful.
You
I
look
am
wonderful.
wonderful. Thank you.
I know
Happy to
you have,
join.
yes. This week is also, or yesterday was considered International Day of Women. And we will be having the women on this evening. The men are too busy for us, I suppose. But, I want to just extend happy Women's Day to all women. And I told my husband yesterday, after he extended his greetings, that every day I think is Women's Day because a woman is working pretty much every day and taking charge and doing the things that she needs to do. Okay, while we wait for the other guests, we'll start in any event because I was going to give Dr. Dean the first question. And Dr. Dean, I want you to tell the audience, the listening audience, what is glaucoma?
Well, glaucoma is a disorder of the eye that is caused from the drainage system being clogged. And because the drain of the eye system is clogged, it causes a fluid buildup in the eyes, which can cause damage to the back, which is the optic nerve. And that is the nerve that leads into our brain and allows us to see. So, damage to the optic nerve can eventually, if glaucoma is untreated, can eventually lead to blindness.
Um, it is kind of considered a group of diseases, also, along
Yes.
with what she said. It's considered a group of diseases and it can damage, ultimately, it can damage the optic nerve of the eye. Now, Dr. Dane, explain to the audience what is the optic nerve so they will know exactly what we're talking about.
The optic nerve is the nerve that's in the back of the eyes that leads to it leads to the brain, to a section in the brain that allows us to see. The optic nerve receives vision from light, from whatever we see from the outside, and it translates it in the brain for us to be able to see what we see in the world.
Yeah, the optic nerve, as she said, is a very, very important nerve. It's probably one of the most important nerves because of all the main senses. I'm sure sight is the one that nobody would prefer not to lose. You don't mind not being able to taste, smell, and the other things, but we know how important vision is. And the optic nerve is one of the main nerves that brings vision to the eye, and it connects, as she said, from the brain. And so, as she was talking about the optic nerve, it's like a tube. And inside that tube, it has lots of bundles that we call fiber. And so those fiber connect to different parts of the eye called the retina. And the retina is where we get the sensory vision to be able to see. And so if we think about it, as she was saying, and we think about the disease, think about a tube and think about small wires passing through that tube. And over time, if those wires get damaged or if the connection gets damaged, then obviously that will lead to problems. And it's the same thing that happens with glaucoma. And so that's how you have to think of it. Think of a tube. Think of the tube having fibers that pass through. And as time goes on, if any of those fibers get damaged or there's some disconnect or whatever, then that'll ultimately affect the vision. And I want to say welcome to our third guest, Dr. Charlene Wallace. Dr. Anita Dane is from MJB Optical. Dr. Charlene Wallace is from Family Eye Care Practice. And I am Dr. Abby Shera Jackson, your host from Palmdale Vision Center. Almost forgot. Welcome, Dr. Wallace.
Well, good afternoon.
Okay. Now, we started our discussion, and Dr. Dane spoke briefly on what glaucoma is. I want you to further elaborate to our listening audience, Dr. Wallace, as to the types of glaucoma that you can see or that shows up or what is stated in the textbook. And there are many, but the main basic ones.
There
I
are
want you to
yes.
elaborate on those.
Okay. There are many forms of glaucoma, but the more common ones are going to be the narrowed angle glaucoma or closed angle glaucoma, and then the open angle glaucoma, and which is the most common one, and actually has been coined the sneak thief of vision, because that is the one that there are no symptoms, there is no pain, there is no indication that the pressure in your eye is high, there is no indication that you've lost any vision, that your nerve head is larger. And so that is the more common one that we find, and that's why it's been coined as the sneak thief of vision.
Okay, so she talked about primary open angle glaucoma, which is I would say 60-70% of the population. Narrow angle glaucoma, and that one shows up in patients and it comes with pain and other symptoms. That is the one you will diagnose quickly, because
very
the
quickly
patient would tend to come in with symptoms. They will know something is wrong. And then you can get a glaucoma from certain diseases, diabetes, hypertension, iritis, inflammation in the eye, trauma to the eye can also cause glaucoma, neovascular, all these things, yes, bleeding. Any of those conditions can predispose you to glaucoma, especially later on in life. I've seen patients who had early trauma and later in life, even certain cataracts, depending on what's happening with that, can
makes it worse.
Glaucoma.
The cataract can block the angle. And there's also in the open angle glaucoma, now we have, they have two categories, remember, the high and the normal tension glaucoma.
Normal tension as well as,
So explain that to the audience, Anita. Normal tension and high glaucoma.
Okay, well, normal pressures of the eyes, we would say, in terms of numbers, run between 10 and 20. So patients that come in and have like pressures of 25 or anything over 20, we're a little concerned, and they could fall into the category of the higher tension glaucoma. But you also have patients that come in and their pressures are within 10 to 20. And you notice when you look at the nerve, because there's different things that we look at to do a final diagnosis of glaucoma. But when you look at the person's nerve and you check even a visual fields test, you notice that even with the normal pressure between 10 and 20, they are still nerve
damage. Yeah.
Right. Yeah. So you still have to treat those patients as well.
And in most cases, these patients are coming in and they have no symptoms, no complaints. Let's talk about symptoms. Are there any symptoms associated with glaucoma, Dr. Wallace?
With closed angle glaucoma, yes, there's going to be pain. There's going to be headaches, red eyes. It's going to be a lot of pain. It's usually very excruciating when they're coming in with closed angle glaucoma. But when it comes to open angle glaucoma, you may hear a patient say, oh, I needed to be able to pick up something off my nightstand and I had to make a turn all the way over to the right, which would indicate that they have lost vision on that side. But there is no pain. There are no symptoms. There's nothing to indicate that that there is a glaucoma happening in their eyes at all. And so it is a matter of just being diagnosed when you go for a routine comprehensive eye examination. And it has to be it has a comprehensive evaluation in order for it to be diagnosed that is what's going on, not a screening, not you read some letters on a chart. It's a comprehensive evaluation when we can make the diagnosis that there is open angle glaucoma.
And a lot of times when patients come in, I'm just adding to Dr. Wallace, but a lot of times patients come in usually when it's at the end stage, or what we call end stage glaucoma, because like she said, they're noticing that my vision is blurry. So they're thinking at that point in time that it's realistically, they just need a new pair of glasses. The
Right.
reason that the vision is blurry, they need glasses. And then when you look in, you see sometimes even one eye's already gone.
Mm-hmm.
The vision's already lost. Most of the vision's already lost on one side. And then you're fighting against time to try and get it under control to save the vision that they have. And that's the one thing with glaucoma is that once the nerve is damaged, it is damaged for good.
Yeah,
So
once the vision is lost, it's lost.
it's
There's no
lost.
way to regain it. And which is why the emphasis that we always have is preventative eye care. And if you were to go ahead and make sure that you have routine, regular eye examinations, and that means examinations at least once a year, it puts you in a better position for it to be diagnosed early, and us to be able to detect it at an early stage and to be able to treat it to preserve your vision.
Yep.
I just want to reiterate some of the symptoms of closed angle, or what we call narrow angle glaucoma, because it can present itself in a interesting way sometimes in your office, and unless you check the pressures, some of the things would include severe eye pain, as Dr. Wallace said, redness, headaches, maybe on the side that it's bothering them.
Yeah.
Sometimes the vision could be blurry or fuzzy. Halos around light is a big one.
Mm-hmm.
Patients will come in and say that they're seeing a ring around the light, and that should cue us immediately that, hey, a possibility of narrow angle. Sometimes the pupil could be dilated, and some of these patients also present with nausea, vomiting, really sick.
Mm-hmm.
And if it's diagnosed with that, then it's considered more or less a medical emergency, because you have to treat the patient almost immediately to try and get the pressure stabilized so that they will be able to function and pull through. But we're going to talk about treatment in a few minutes. Now, Dr. Wallace mentioned loss of vision. And I just want us to go over that again in terms of what sort of symptom you will get if you have primary open angle glaucoma.
You're not going to get any symptoms. There's
a symptom, but something you said that you'll notice.
Well, what you may notice is that you're not able to. You find that you want to reach for something, and the most popular thing you would find patients saying is, "Oh, I was trying to reach for something on my nightstand, and I realized that I had to turn all the way over to the right to get it, or I had to turn all the way over to the left to pick something up." Many times, that's a very important indication that you've lost that vision, because under normal circumstances, your standard peripheral vision would allow you to sit in your bed and glance at your nightstand and see whatever it is you want to see. But when you then have to go ahead and make a concerted effort to turn all the way to the right or to the left, that should be an indication that something is wrong, that you have to go ahead and turn in such an important way, or such as a determined way. You have to make the turn to go ahead and look for something. It should be a trigger to you that something's wrong.
And it's loss of vision on whatever particular side. That's the main thing. And that is something, Dr. Dane?
No, I was saying it's peripheral vision that goes first.
Right. Yes.
So it's the side vision that gets lost first.
A lot of times also you find these patients are driving. And when they're driving
because what happens is their straight ahead vision, that central vision, which that central vision for them, they can still see in that central vision. So as far as they're concerned, everything's okay. They're not noticing that when they glance over to their left or right, they're really not seeing what's going on. And because there's no pain associated with it, they think nothing of it, they make the adjustment without even knowing that they're actually adjusting their body to be able to see. So because that vision that they have straight ahead it's like what we call it tunnel vision. That's they still see straight ahead. Many times they think that nothing is wrong.
Well,
And
why
okay.
I brought up driving is because you have a lot of patients who are driving and they're accident prone as a result of that. That is the point I wanted to reiterate because, as you said, they can see straight on, but suddenly somebody could pull from the side or the corner and they're like, where did they appear to so quick? Where did they come from? Not realizing that if they don't make a turn, conscious effort to turn, they probably won't see. And so we have a lot of people in our country who are driving around with this particular disease and really cannot see to their side to be able to manage themselves for accidents. And that's the point that is very concerning here in our country because I see it a lot of times with the patients. And many times I'm asking them, are you driving? And they're like, yes, but I can see. Yes, you may be able to see in front of you, but you're not conscious of what is happening to your side.
Which is why it's been a lot of insurance companies are requesting that as drivers get older, they have to be able to fill out these medical forms. And the medical forms always ask us not only about their visual acuity straight ahead, they often ask about their peripheral vision as well, because that's a very critical part of being able to see properly. It's not just your central vision, it's also your peripheral vision.
Dr. Dean?
Yes, and listening to all of you, the point too to make mention of is because open angle glaucoma is a very gradual thing. That's why a lot of times people don't notice it right away.
Yeah.
So it's not like closed angle glaucoma that a lot of times happens suddenly. And that's what causes the pain and everything because the pressure shoots up very quickly and the angle closes. But open angle glaucoma can be a gradual thing. I've had patients that have been to me 1 year and everything is fine. And then 5 years later, they come back and one eye has been lost. So the key is that because it's gradual, it's very, very difficult for the patient to notice until it's at the end stage.
Now, that brings us to a point because Dr. Wallace talked about insurance companies and older. Let's talk about glaucoma in children and younger people because it is becoming just as common and prevalent, especially in our population, a Black population. As you know, glaucoma is popular in the Black population, in Norwegian countries, in some of those areas, in Latin America, Latinos, Hispanics, and in certain Jewish populations, I've been told, yeah, you're seeing it. So what about children and glaucoma? What are you all seeing in your practices or here in our country? Dr. Dean?
I haven't seen much children.
Well, teenagers, young adults?
Young adults, yes. Yeah. I guess, again, because of our,
ethnicity,
everything else and all of other things, obesity, hypertension, diabetes, all of these issues that we're having now. We're not only having it in adults, but now because of, just like someone said, obesity, we're having these issues with children. So now you're getting, because with these other issues, you are at a higher risk if you have diabetes or high blood pressure or any of these diseases, you're at a higher risk of having glaucoma. So yes, we are seeing more in teenagers and young adults, the same way you would see it. Usually glaucoma is technically supposed to be hitting around the age of 40, but now we're seeing it younger because of our population and our, I guess, way of lifestyle.
Dr. Wallace, you're in public health at this point. What are you all seeing in there coming in terms of young adults or even children?
Not as much as in children. You may have a couple incidences where You may find it happening in some children, but you're going to find it more in the young teens and persons in their early 20s, particularly, like Dr. Dean was saying, when you find that there are some of those, like we call it comorbidities, those underlying conditions, and especially when there is family history of glaucoma.
Yeah.
That
Big one.
that is a big, I mean, that's a major factor. And so taking the proper family history, just taking proper history when you're evaluating a patient becomes very important, because the fact that there is glaucoma in the family, and sometimes they're not able to specifically say it's glaucoma, but maybe you're able to describe it for them where they've seen their parents or grandparents put drops inside their eyes every day, every night. That certainly serves as a major indicator to us that, yes, they did have glaucoma, and that when you look at it in terms of those younger populations, it is something that's becoming more prevalent.
I have a family that come to my practice where mommy, daddy, and both children, mommy, daddy, and daughter, they all have glaucoma. And the dad came in first, and by the time he came in, because somehow the men just wait and sit on these things, he was quite advanced in one eye. He's lost quite a bit of vision in one eye. But for some reason, the mother, the wife, was just as lackadaisical about it herself. And she used to come in with Precious in her 40s, okay? And just taking it lightly. But let's talk about treatment now. Let's move towards treatment. Dr. Dane.
But before we even get to treatment, I think the reason why so many people take it lightly is there's no pain. You know, we often associate something being wrong with pain. And because there's not a pain factor, we spend so much time trying to help our patients understand that there is going to be no pain. But by the time they realize the importance of really adhering to the therapies and the recommendations we have, it's so much vision that's lost. And, you know, you try to emphasize when it's gone, it's gone. You can't get it back.
I don't want to move to compliance yet, because that's a big issue that needs a little
Yes.
discussion this evening. You know, very big issue. But let's talk about treatment. Start with you, Dr. Dane. What would be treatment options for primary angle glaucoma, the open one? I mean, narrow angle glaucoma, we know this is, but primary.
Yeah. Primary open angle glaucoma, usually when it's diagnosed, the first line of treatment is with drops. So you would start off, there's varying classifications of drops, but the drops realistically is supposed, some drops, some in some categories tend to lower the amount of fluid that is produced in the eyes. Some open up the angle, some open up the blood vessels along the side to allow fluid again to flow. But that's the first option. If we cannot get it under control with drops, then surgery is indicated. So there are various surgeries. You can have laser surgery, or you can have what we call a filtering system, where a tube can be placed in to be able to allow the fluid to be able to flow out.
Now, Dr. Wallace, Dr. Dane spoke about drops. If a patient comes in and you're gonna start treatment, explain to us the form of drops. We start with this, and then you explain that process to the patient.
Normally, you want to go ahead to try to get preservation as best as you can, particularly of the nerve head. So you would try to go with the first form, the prostaglandins, to you trying to be able to help a patient to, again, we have the tip in there, compliance, you're not getting to that yet, but you want the patient to be able to have the easy way of being able to use medication on a regular basis.
Now, I want to stop you right there. We're talking about that, but my question is, do you start one drop, two drops, three drops first, or three different drops, or how do you go about
It all depends on what you see. It depends on what the nerve head looks like, what the pressures look like, what you when you get some imaging done, what that looks like. It depends on the family history as well. And so then you make a decision based on whether you start with one drop or whether you actually start with two drops or whether you start with a combination of drops. Because you really, the thing is, you can get up to maximum therapy, but you really want to be able to find out if you could have the minimal medication to give maximum effect. And so that is what you want to do because you want the patient to be able to understand that when this condition is diagnosed, this means this is it's for life.
It's a lifetime disease.
It's
Yeah,
not like you could
exactly.
take medication and you take medication for 6 months and then you come off the medication. You're on medication for life. So
Yeah.
we try to find the means of prescribing medication that's going to assist with them understanding that this is a lifestyle change. And so you want to make it as easy as possible to make sure you can have them be consistent at taking the medication and it to be effective. Now, just as they didn't know that they had glaucoma or pressures were elevated or they were losing vision, they're not going to know when it is what the effect of the medication. So it is important that you come back for your follow-up visits because that is the only way that we're going to know that the medication we're giving you actually is effective. Because if we start off with one drop and we're not getting the response that we want, then we have to add more drops to it.
Yeah, the goal initially is to start the patient on the least amount of drops needed and necessary because it's like all the other comorbidity type diseases. You're on these medications for life, and patients have to begin to plan their lives around this
Yeah.
thing. And a lot of times I would advise my patients to try to use the drops around the same time
Right.
each day. So you could imagine if, depending on what you're doing, if you're working, exercising, all these things. And so you have to incorporate treatment into your lifestyle. And for a lot of people after a while, and I don't want to get to compliance yet, they get tired, they get weary,
Yeah.
all of these factors are involved. Now, a question somebody asked.
So,
Okay?
oh, I was gonna add, just another point. You're taking it because glaucoma is a disease that there is no, because some people would ask, is there a cure for glaucoma?
Yes.
There is
Yeah.
no cure for
Cure.
glaucoma.
You
So
know,
that is the reason why we're talking about once you are on the medications, you're on the medication for life. So basically, we are trying to stabilize the glaucoma and keep it where it prevents damage to the eyes and eventually loss of vision.
Yeah, unfortunately, there is no cure. You hear that all the time, Doc. How long I have to be on these things? And it's like, well,
for life.
it's going to become your life because if you don't try to take it and to stabilize your pressure, eventually you will continue to get vision loss with time. Question is asked, and to either of you, anyone, says, when does a patient get referred to ophthalmology? Dr. Wallace, because you work in public health. What happens there? Then we'll start today.
Certainly, you can go ahead and consult or refer at any point in time, particularly because we're working in a clinic or environment where I'm working along with ophthalmologists. We work in a way that if for any reason we need to be able to speak to we have a really good relationship where either of us can go ahead and speak with each other about patients. And so it's not that, oh, we have to wait for a specific time for it to happen. If there's a particular concern, if there's a question that needs to be asked or addressed, it's a very open forum where we can speak with each other in regards to that. So there's not a timeline that it must be, oh, well, I have to wait until this certain time to be able to do a consultation. No, that's not the case.
Dr. Dane, in private practice, what do you do?
Usually, if I'm not able, because we as optometrists are able to treat glaucoma to the point of where it needs surgery. So, if you are with me, if I'm realizing that I am not getting stability with the pressures, with drops, with all the drops, and we've maxed out the amount of drops that we can use and even tablets at that point, then I'm going to refer for surgical intervention.
And I think the public needs to be aware, at least here in the Bahamas, most of us optometrists, we're trained to treat glaucoma.
Yes.
Optometry is involved in treatment of glaucoma and even some laser and surgical procedures in the United States and other parts of the world. And fortunately for us here in the Bahamas, you don't realize how many trained eye care professionals you have. There's always a conversation of, no, you should see them. This is a medical condition. They should see the ophthalmologist. But we pretty much diagnose the same diseases and conditions. We can order some of the same scans and tests to be able to verify and to see how severe the damage is and manage the patient. Now, we all know what our scope is. And if it's something that it's beyond your scope or that you feel comfortable with, then you refer it to the ophthalmologist. But I think here in the Bahamas, they also need to recognize that even not every ophthalmologist is trained to treat glaucoma. That's a specialty.
Yes, it is a specialty.
It's a specialty. So because you go to an ophthalmologist, that does not negate or necessarily mean, oh, because they're an ophthalmologist, they can treat the condition. You must remember that there are ophthalmologists who are trained specifically to treat and deal with glaucoma. Now, here in the Bahamas, we have ophthalmology treating all different types of conditions.
General ophthalmologists.
Well,
So,
the other,
Dr. Wallace?
The other thing I think that the general public also need to understand is that we're going to operate in the best interest of the patient. And so we're going to do what's best for the patient, make the recommendations when it's necessary, make whatever is needed for the best interest of the patient. That's what we're going to do.
And I think that is the one thing that optometry does here in our country.
Yes, we operate in the best interest of the patient.
For the most part, patients are managed to the best of their ability. And when it's something that needs to be referred, it is referred. And in most cases, once it's referred and it's stabilized, it should be referred back to the optometrist in any event. Or sometimes the patient would come back because ophthalmology is mainly surgery or medical treatment, depending on what is going on with the eye.
Yes.
So, yes, those are a lot of the treatment options that are available. You have topical drugs, you have oral drugs, and the oral drugs are not used as frequently now as before because in the past they were quite debilitating on the body.
Yeah,
you know,
they were exactly
older. They were stronger drugs, and so now the newer drugs. Dr. Wallace talked about the prostaglandins, and we don't want to get into too many fancy words for our audience, but those are the newer type drugs that really treat and manage glaucoma very well. Now let's talk about some of the side effects of these drugs.
Well, before we even get to that, I think patients also need to understand, because many times when we're taking the medical history, we're asking them about medication that they're taking. And they have to understand that we are asking that because when we're having to prescribe medication, we are concerned about the drug interaction. We want to make sure that the drugs that we're prescribing are not working in a negative way with medication that they're already taking. So unfortunately in our society, because hypertension is so prevalent, you go to ask patients about medications that they're on, and you have to be specific because many times they'll never tell you they're on high blood pressure medication because they just figure, okay, everybody's on high blood pressure medication, so I don't need to say that. But in part of our history, that is why we take the history as detailed as we do, because we have to be concerned about drug interaction when we're going to prescribe any medication for you to take.
Now, Dr. Dane, we could talk a little bit about some of the side effects from glaucoma medications that your patients complain about. Because we all know for most drugs, there is a slew or list of side effects. I mean, notice drug companies write in small script because they really don't want you to see all the side effects. And most drugs come with 1,000,001 side effects.
Yes, yes.
But what are some of the main side effects that your patients come in complaining about or that they will experience after being on glaucoma medications?
One of the main ones is red eyes.
Yeah.
Mm-hmm.
So, I mean, we haven't talked about compliance yet, but that is one of the big things, that it burns, that it's red. Dry eyes are
Major.
yeah, very much so. So those are some, I guess we're still like sneaking around compliance. Reasons why also patients end up stopping the medications, because initially they come into your office with no complaints. You finally tell them that they have something going on with their eyes. You give them something now that's causing issues, that's causing redness, that's causing all these issues. It doesn't make sense in their head. I came, I was fine. You tell me I have to take these drops, and now my eyes are irritated.
Eyes are red, exactly.
What about taste? Tasting the medication, burning, stinging?
Eyes, ears, nose, and throat are all interconnected.
All connected,
Whatever
exactly.
you put in your eyes, you can blow it out your nose or you can taste it.
Yeah, those are the main symptoms that patients and some complain with dryness, Dr. Wallace.
But sometimes they talk about the extra growth of their lashes.
Oh, yeah.
Well, that's the beauty of it.
Yeah, that's the
Yeah,
beauty for a
beauty of it.
female. For a
The
female, not necessarily a male.
That's the beauty of it. That's what people don't realize. When you have glaucoma, you have beautiful lashes after using those drops for an extended period of time.
Yes.
And by the way, to those ladies out there, that's the same sort of topical drugs that they use to grow your lashes, you know.
Yeah.
And they do wonders. But side effects can become a challenge. So let's move now on to compliance. Because of the side effects, Dr. Wallace, what do you find with compliance with your patients?
Because of those side effects, many times patients will just stop taking the medication.
Mhm.
And they'll say, well, my eyes were hurting, or they got red. And, you know, people are thinking that I'm indulging in acts that I wouldn't normally do. And so my eyes are red all the time. And as Dr. Dean was saying, oh, everything was fine before. Now you have me on these drops and my eyes are red. So that becomes an issue. Yes, it means that we have to be able to find other ways to sometimes help you with that, so that it is more soothing, so that redness does disappear. Sometimes it is a matter of us switching medications. And that's the other thing why we say to patients, it is important. It is a long-term relationship that you're going to have with your eye care provider, because you may get started on one medication today. You may react in a certain way, and it may be that we have to make a change in the medication. And so those are the kinds of things. So we make the change, and whether we have to add something to it, make an adjustment to it. Those become very, very important. And so it's one of those things where even though you may find that you have initial discomfort, do not stop taking your medication.
Yep.
If you have a problem, there's something you're not happy about, please speak with your doctor before you go ahead and do anything. And then give us the opportunity to make the adjustments to help you to be able to be comfortable and still be compliant. We want to preserve your vision.
I had a patient who, when he came in and was diagnosed, he had pressures in the 40s, right?
Mm-hmm.
One eye damaged. I mean, he still has vision in that eye, but it's quite damaged. After, I guess, 2 years have been on drugs, or even a year, he decided, and he didn't say anything to me, he was going to stop the medication to prove, to see, if he really needs to be on this. And so he stopped after his last visit. And then I saw him like 6 months later or 3 months later, but he was trying to run his own research, do his own research too. So he didn't tell me. He wanted to be able to come back in and say, you see, I don't need to be on this. And right away, the pressures were in their 50s at that point. And I asked him, I said, are you taking your medication? And, he was embarrassed. And he said, no, doc. And then he explained to me, I said, well, anyhow, I want you to drink it from now on, okay? Starting every day, to drink the drop if you have to. But make sure that you are compliant and you take your medication. People don't understand the risk involved once you start to lose vision in your eye.
Mm-hmm.
And it's unfortunate. Dr. Wallace?
I try to go ahead to say adapt it to something that they're going to have to do on a daily basis.
It's like their hypertension and diabetic medications.
Whatever you're going to do on a daily basis, you have to be able to find a way. Listen, every night before you go to bed, you're going to brush your teeth or you're going to have a cup of tea. Well, then attach the medication to your toothbrush. Put it right there where you have to be able to see it. In the morning, there's certain things you do. Automatically, try to make it a part of your regular routine. Because that way, then it's not an extra effort for you to say, oh, I have to try to remember this. Because if it's something you do every day, twice a day, 3 times a day, it makes it so much easier if you associate it with something that you have to do and you do on a regular basis. We don't want it to feel like it's an extra chore. When it's something that you have to do for the rest of your life, you need to make it a part of your life.
And remember, it is a thief of vision. So if you stop, remember that thief is coming after your vision. So
The sneak thief, because it's quiet.
Yeah. So sometimes I even get, like if it's husband and wife, I'll even get the wife or the husband involved. And sometimes you have to be really harsh and say, okay, if it's the husband, wife, do you want to in 5-10 years be able to have to lead your husband around? Then you need to be accountable to him as well. If he's not taking his drops, make and ensure that he takes it. So sometimes just finding someone else, if they have a family member that's close to them, making them more accountable as well can help as well.
Well, it's particularly in the older population where many times they don't have somebody else that's around. It is important, particularly if they have a family member come with them, so you can really explain the importance to them, because it may mean to have a series of persons who may be able to go ahead. Grandchildren that maybe have to understand that, listen, Grammy has to put these drops in or Grandpa has to put these drops in. So they have to make the effort to make sure that somebody goes ahead to do it. Many times these older people are able to do it, but sometimes they're not.
And then dexterity is a problem, because that is a major problem with elderly
That's a major exactly. And see, the thing is, many times people feel that, well, okay, I didn't put my drop in last night, so tonight I'll put 2 drops in, one right after the other. Well, it doesn't work that way, because even the way the bottles are designed, they're designed that 1 drop is going to fill the eye and some will spill over. So you put 2 drops in, but the second one totally wasted. And the cost of the medications,
it's costly.
It is costly. So you don't want to be able to waste the medication. You want to be able to utilize it to the best as best as you can to benefit from it.
That's a good point about putting in the 2 drops, yes, because you have patients who think if I miss today, then I can put in 2 tomorrow or 3 the next day or whatever, and you're only wasting a drop. The eye only needs really 1 drop of that medication. And as long as you can put your head back enough, or even try to get it into the corner of the eye and just hold and try to maneuver it to get in, it's so important. But yes, with a lot of elderly patients, depending on their dexterity and their mobility,
yes,
it can be a challenge for them getting the medications in. So you do need assistance and someone around who is going to assist with that and make sure they be compliant. Now, I wanted to
And
ask you all about. Mhm.
let me also make another note on that same thing. We also talked about sometimes putting patients on 2 or 3 drops. So also, just like Dr. Wallace say, putting drops in back to back, one will roll out. So if you have 2 or 3 drops, and sometimes you're taking 2 drops back to back, please wait at least 10 to 15 minutes before putting in the second drop, because that same thing will happen. You put in 1 drop, you put in the next drop, the second drop has no effect on the eyes. And you find sometimes patients will come back and the pressures and something is wrong. Like you put them on 1 drop, you put them on the second drop, and you're getting no effect from the second drop, and you're asking why. And just listening to them, how they're applying or putting the drops in, you realize, okay, because sometimes you may say, well, geez, this person is not even, the drops are not working. Is the next step, maybe I need to refer to an ophthalmologist for surgery. But just listening to how they're taking the drops, you realize that that is the reason behind us not getting the effect that we need. So make sure that the drops that you're taking, if you're taking it back to back, make sure it's separated 10 to 15 minutes apart.
Now, what about exercise? Think about it. You have this fluid inside the eye, and you're trying to get rid of the fluid in the eye to lower the pressure. Exercise is supposed to get rid of fluids in the body. When we exercise, we excrete, we sweat. Is exercising, does that contribute to helping to lower pressure? Dr. Wallace?
As far as I am aware, I haven't seen any studies that give that kind of indication. Yes, exercise is important. It's important for the natural balance of the body and everything else. But that has not been proven to be a way of, certainly exercise does not allow us to excrete any other intraocular fluids. So as much as it may be able to get rid of excreting fluids from the body, otherwise, I don't know of any science or any research where it can be proved that exercise has allowed you to be able to get rid of any of the fluid that's inside the eye.
Dr. Dane, you know of any? No, why I'm asking that is because several years ago, they were doing studies to try to prove whether or not exercise would help to lower IOP. And for a period of time, they were saying it, but over time, they realized it really was not making a difference. But I say to patients, it won't hurt to exercise, you know.
No, it doesn't.
It won't hurt to exercise. It may lower it by 1 millimeter, a notch, and that's good. But there are no studies out there that is significantly saying that exercise helped to decrease your eye pressure.
That exercise
may help. Oh, I was going to say exercise may help with other things. If you're diabetic or hypertensive,
that too.
a little overweight, so it may help on that sense. So if it helps on that sense, then it could.
You may have a cumulative effect eventually.
Exactly.
Well, the other thing is exercise is good. It's going to help with your flexibility. And so then the mobility that you would need to put your drops in your eyes, you could be able to do that with a lot more ease in that case. So
the final thing we want to touch on, and we have to touch on this evening because I had a patient in office just before I left telling me, Doc, when are y'all going to legalize cannabis so you can use it for glaucoma? Okay. Let's get your opinions and take on cannabis for glaucoma use. I'll start with you, Dr. Wallace.
You know, that is an age-old...
Cannabis, the medical name, not Mariana. Cannabis.
That is an age-old question, one that they've been researching for a long time. And they have found there were times when, yes, the use of it would lower the intraocular pressure, but never be able to sustain the intraocular pressure. And besides that, the other side effects that came along with it were just negative. So it never became an alternative because certainly there was no sustainability. in its use. So it had lower the pressure, but not low enough that on a consistent basis that can be used as a viable alternative and treatment mechanism. And as I said, a lot of the other side effects from that standpoint have all been negative ones, that it was never an alternative.
Dr. Dane, your take.
I know because I've been in a few continuing ed classes, and in the States, I know they've been talking about it. So the research is being done on it. And I think because the raw, what you call the raw marijuana or
The
cannabis.
THC.
Yeah.
Exactly. So I know that they're looking at a lot of research in terms of making it in a drop form that will help. So I guess there is some benefits to it, but at this point, the way it's being taken, it is not as beneficial. So they're trying to make it where it is beneficial to glaucoma and for the eyes.
But
So,
they've been researching that for a long time.
yes, yeah.
Um,
But it's coming close. It's coming close.
But they've been researching it for a long time.
Yeah, because a lot of it does have medicinal benefits across the board. So eyes are going to be in that as well.
Yes, I have several patients who have glaucoma and they take marijuana because it's not legalized here, and it's certainly not recognized as cannabis here. It's pretty much marijuana.
Correct.
And it does lower their pressure and keep it low. But as Dr. Wallace said, taking the marijuana itself, the positive side effects and the negative side effects, there is an imbalance. So even though it may lower your eye pressure, there are those other side effects that affect the body even more serious. But a lot of times, sometimes I have to say to them, listen, just ease up off the stuff so we can at least get a true pressure reading, because in most cases, you never know what the pressure reading. And then too, if a patient is on it and they come in for an eye exam, you may not even know they have glaucoma. That's the other issue with it. A lot of times, if patients are on it and they have glaucoma, you will never know, especially if the nerve is not showing any damage at that point in time. But sometimes you have to question patients and ask. Some cases, I've had to ask some, listen, is this what you want? And one or two cases I've had to put the parents out just to say, let me engage the child or the young adult and just ask, because in most cases you would not know they have glaucoma, especially if they're on marijuana.
Have been on it for a long time.
Yes, yeah. And as Dr. Dane was saying, cannabis, which now they're changing the name of the drug. It's not being considered or recognized as marijuana, but it has a more sophisticated name, cannabis. But it does have good medicinal.
But it's
purposes.
It's the form. It's the form, the format from that standpoint. And so, see, the thing is, it's in most cases with the patients that I've had that have dealt with it, many times it is that they're impaired otherwise, and you determine that even in an examination sometimes. So, which is why, as you said, let's ease up on it so that we really could be able to do the kind of evaluations that need to happen.
And eventually, as Dr. Dane said, you will have cannabis, glaucoma medication that's from cannabis to help treat glaucoma. And I'm sure it will have its place in medicine because it will be able to manage patients who fall within a particular category and not showing too much nerve damage to the eyes and so on. So it's going to happen, but until it's legalized in our country, it's against the law to. We can't prescribe it for one, and we don't encourage patients to say, well, listen, go smoke marijuana or go take some THC or see how else you could get it. Our job as eye care professionals is to manage you in a legal way to ensure that the best treatment option is provided for you in our country.
Yeah.
Now, as we begin to wrap up, ladies, starting with you, Dr. Wallace, what would you say to the listener out there who's listening this evening in terms of the importance of having your eyes checked, what glaucoma is all about? What would you say to our listening audience? And if you have any questions out there, you can just send them to us quickly if you wish.
What I would say is, you know, love yourself. And if you love yourself the way you should, you are going to want to preserve your eyes, your health, all that you have the power to do. And so it is going to be important that you have regular eye examinations. You know, it's amazing how many people really have never had their eyes examined. But your eyes are the most precious gift. They can't be transplanted. We can't go ahead and give you an exchange at any point in time. It is important to have regular, comprehensive eye examinations to be able to properly evaluate your eyes. And you ask me regular means once a year. You can't go
Well,
ahead.
if you're diagnosed with glaucoma, you're
Now, if
saying
you're
even more
diagnosed with
frequently.
glaucoma, if you're diagnosed with glaucoma, it is important that you listen to the advice of your eye care provider, who's then going to tell you how often they need to see you. They're going to tell you if you need to have a scan done, if we need to have certain testing done, certain scans done. That's going to be important to be able to help us monitor your condition even more closely and to manage it more effectively. So it is going to be it's the marriage or the relationship that you're going to have with your eye care provider for life.
Dr. Dane, you do a lot of family island visits. What do you see there among a lot of the elderly patients?
The most common thing is the open angle glaucoma. Primary open angle glaucoma is what we see the most of.
You find in a lot of these family islands, a lot of our elderly patients have advanced glaucoma.
Mm-hmm.
And because they don't have access to eye health care as readily as someone in Nassau, a lot of these people are going blind and losing their vision with time because of glaucoma. It is so important and imperative to patients on the family islands, on our family islands. If you're listening to us or you can hear or get the information, the importance of trying to have their eyes examined, because too many of them are going blind because of glaucoma on our family islands.
Yes.
And there is no need for that if you can get help. Unfortunately, finances can be a challenge for one, because it means that they would have to travel more frequently to have pressure readings done and then to be able to get the medications on a consistent basis. But I say to persons, if you have elderly parents on the family islands, ensure that their vision is checked and monitored on a consistent basis, because if they want to live alone or be alone in particular, you have to ensure that they're able to see properly, because that can affect their lifestyle. Now, a question is asked, is glaucoma curable and can you get rid of it?
Oh,
yeah, that was
we answered that. Yeah, it is. There is no cure for glaucoma. No cure. So once
it's treatable.
Once you've been
treatable.
Diagnosed, we can treat it and manage it. We can manage and treat it, and that's why Dr. Wallace was saying that the only way to be able to diagnose it is through comprehensive eye exams. And once it's diagnosed, we can manage and treat it and follow up to ensure that if there has been any. Sometimes you can diagnose it at the beginning where a person really doesn't have any significant vision loss, and you can maintain it. But even if that is the case, then follow-up visits are needed to be able to ensure that we continue to manage it to prevent vision loss.
And yes, you can get rid of it. You get rid of it by taking your medications. That's how you get rid of it. you know,
Well,
you
that's the
start their
control.
medications over time, and hopefully that you will get
life.
rid of it like that. But yeah, there's
Well,
no one-stop cure that
well,
will
not only
say.
that. Yeah, just understand you may go ahead and be never. You would have to be on that medication though for the rest of your life.
Yeah. So that's how you get rid of it, by
Yeah.
taking that medication for the rest of
Rest
your
of your
life.
life. Yeah.
You
You
know.
stabilize it.
Yes. Any final words on it before we end our session this evening? We know that glaucoma is very prevalent. It's one of the leading causes of blindness worldwide. It's very prevalent here in our country,
Worldwide.
especially in the Haitian population. Very prevalent. And a lot of times they don't come in until
The end.
they realize something is wrong. And for the average Bahamian person, if there's a family history, and I find a lot of times, and that's the one thing I say to patients, if I suspect it's glaucoma, I tell them go home and research your family on both sides. Ask mommy, daddy, auntie, uncle, cousins, whatever, because somebody in there had it and they're just passing it on. It did not start with you.
Yeah.
Another question is saying are ocular migraines a sign of glaucoma?
No. No.
Why do you say that,
Because
Dr. Wallace?
the thing is we just finished saying that you really, when open angle glaucoma, there are no symptoms. There's no pain.
No.
There's nothing associated. So having an ocular migraine does not. There's no correlation to say that's glaucoma
Related, at
related.
least the
No,
primary open angle
not
glaucoma.
primary
Now,
open angle glaucoma. The
now
pain can be
you-
there if you're having closed angle glaucoma.
right.
Now,
I
that's a
mean, you'd have to
totally
rule
different
that out.
Yes.
Yeah.
But closed
yeah.
angle glaucoma, you can have excruciating pain. You can have a migraine. You can have the pain that you can get can be really, really bad. But for open angle glaucoma, which is the most common form that we're speaking of, no, that you can't. An ocular migraine would not be a symptom of that.
They would have
ocular
Dr.
migraine,
Day.
you end up having, I guess you have visual auras, which people have like wavy lines, halos, big spots, or whatever.
Yeah.
That's an ocular migraine. But that is based on constriction of the blood vessels. So that's why you get those before. Sometimes people get the classical headache right after that.
Right.
So that's a sign leading into the migraine. But yeah, that migraines have nothing to do with glaucoma.
Yeah, that's the prodrome or the aura that would be associated with the migraine.
Yeah.
Yeah, glaucoma is one of the leading medical conditions that affect the eye. And we will continue to see it. In fact, a patient came in today and pressures were almost 30 in both eyes, So when we see that, we have to begin to discuss and talk about glaucoma management.
Yeah, but I
going
had a
forward.
patient today who was a gardener and who said to me, I said, listen, I need to know, have you been taking your drops? Because I could see the pressure starting to elevate, particularly in comparison to several of the other visits. And he said to me, you mean I supposed to, like when I outside working, I supposed to use my drops?
Compliance.
And so that's why, trying to find a way that no, before you go outside to do your work or when you come back inside, you need to use them, but you can't just say you're out there working and forget to use them.
Yeah. No, it's a lifestyle condition, as with everything else. Once your health is challenged in some way, and you have to use a particular medication on a regular or daily basis, the thing is to try to incorporate it in your lifestyle and plan. We don't realize the effects until another question is, what is normal eye pressure? Also, does hyper blood pressure affect your eye pressure? And those are two good questions.
Yes.
Dr. Wallace, I'll let you give what is normal eye pressure, and Dr. Dane, you could speak on the second part.
Normal eye pressure usually would range from like 10 up until I would say 22. We start seeing any pressure, even at 22, we become suspicious. But normal will range from like 10 to 20, 21. Anything that starts, we say 21, 22, we start to get very suspicious from that standpoint.
You classified as ocular hypertensive.
Ocular
I mean,
hypertensive, yes.
Yeah, that hey, you can be predisposed to
Glaucoma.
glaucoma with
Yeah.
time and aging, so that's normal. And 10
And
to
it
20
means,
or
and even when you are classified as ocular hypertensive, it still means we need to monitor you, because at any point in time that could change. It can change or it can remain the same, and that's fine if it remains the same and you're not having any changes in your peripheral vision or no changes in the nerve head size. That's great, but the only way we're going to know that is if we monitor you on a regular basis.
and what is interesting too, in the Caucasian population, they're what we call cupping, what we see in their eyes as compared to
Yes.
somebody of a
Who's
black
in of a dark
ethnicity. It's totally different. We
Yeah.
can see severe changes in the nerve of a black person's eye, and they may not have glaucoma.
Right,
Yeah.
But
exactly.
if you see it in a Caucasian eye or another type or another ethnicity, then you would have to think glaucoma almost immediately. But in a
Yeah.
black person's eye population,
A nerve
we,
head is usually,
large.
it's not unusual to have larger
To be
optic
large.
nerve heads.
right, to
Yeah.
see something that's
The cupping,
very
at least.
look suspicious looking, but it may
Yeah.
not necessarily be glaucoma. And Dr. Dane, does high blood pressure affect your eye pressure? And that's a valid question because a lot of
Yes.
times people
Yeah.
think it does. What's your take on that? Is high blood pressure?
Sometimes it can, because if it, I mean, indirectly affect the pressure, because you remember there's blood vessels that are around the nerve. So if those blood vessels are damaged or are constricted, then it can cause issues with the pressure of the eyes.
But it's not related in that if your body pressure is up,
No, it's not.
then your eye
It's a
pressure.
different circulatory system. Yeah, blood pressure or the circulatory pressure in the body is different than the circulatory pressure in the eye.
Yeah.
Because oftentimes patients think if we say the pressure is high or
They
the eye
think-
pressure is high, they automatically think that the blood pressure is high. And no, that's not the same.
No,
Yeah.
no,
There's no correlation between those two
No.
like that.
no.
Well, I think that's our final question this evening. Doctors, you continue to be informative. We continue to do our mandate as an association to educate our people and
Yes.
to advise them on diseases and conditions that will affect the vision and will affect the eye. That is the sole purpose of our association, to educate our Bahamian populace. And the more we educate our people, the more informed they will become, and they will be better able to make decisions that is for their better
Best
interest.
interest.
So we want to say thank you again to our listening audience and viewing audience, those who sent in questions and those who just said hi, some thank yous. They called out certain doctors' names, but I won't do that because, we're all favorite doctors in this room this evening. And we're all ladies. But thank you to our viewing audience for listening in on this live vision forum talking about glaucoma. And yes, this is Glaucoma Week, Awareness
yes.
Week. So if you've not had your eyes checked in a long time, this is probably the good time to go in, see your eye care professional, and have your eyes checked and make sure that they're doing pressure readings. And we have to talk about the two types of tools that are used for it. Some persons use the air puff machine. It can be disgusting if you ask me. And then others use applanation tonometry. We need to just mention that briefly, the difference between those, so patients would understand and know what sort of reading they're getting. Dr. Dane, what is applanation tonometry?
Applanation tonometry is actually when we are reading the pressure, when we apply the probe directly to the eye and get the pressure.
Don't tell them to the eye, the front surface of the eye. We don't want to frighten them.
upon using that fluorescein,
We use an anesthetic
using anesthetic and
to deaden
fluorescein.
the eye, and then we place that in the front surface of the eye.
yeah.
It doesn't go
Yes.
in, because when patients see it coming right away there, you know.
Exactly,
But
yeah.
now, Dr. Wallace, talk about the air puff machine. What? Go ahead. What?
The air puff machine is one
Let
where.
me,
Sorry, go
well,
ahead,
before
Dr. Dean. Go
I was
ahead.
going to say the applanation is pretty much our gold standard, though.
Standard, exactly.
So that I didn't, and I wanted to say that before Dr. Wallace starts.
Yeah,
So.
it's the gold standard,
Standard.
no doubt.
There are times that the puff is used by some persons. Yes, it's one of those things where people are trying to keep steady, and for a puff of air to be able to be shot into their eye, which that gives us a certain reading coming off. I'm like you ladies, give me the gold standard. The puff of air requires a lot of different technique and waiting for the patient, and too much apprehension from the patient. And so the other thing about the puff of air, though, is when you get to the higher readings, that's when the puff of air becomes more questionable. And that's why the applanation tonometry is the gold standard, because even with the higher readings, they're more reliable.
And the puff of air is just, I
It's a
see that as a
screen.
screener.
It's a
Yeah,
screen.
right,
Yeah.
it's a screener. But it can be a challenging screener, as Dr. Wallace said, because I remember when they used it on me, just anticipating that puff just
You're
drove
close.
me nuts.
Yeah.
Yeah.
So we need patients and people to understand that, yes, there are two ways. There are other ways, but the two main ways now.
So.
It's either applanation, where they put that probe toward the front of the eye. You see them coming with this blue light, and
Now,
that
hold
is
on.
what should be done.
Right.
Or,
And that
the tonal pin. Do you remember the tonal pin is one?
Yeah, the
too?
tonal
Yeah, the
yes.
tonal pin. Yeah.
Yeah.
And just know that even though that blue light is coming, we're going to use a little drop in there that makes it a lot more comfortable for you as that blue light comes towards you.
Yes. So thank you
won't
again.
feel a thing. You won't feel
Exactly.
Thank you, viewing audience. It was a pleasure bringing this information to you all this evening, and we trust you enjoy the rest of your evening. And we want to say good evening and good night to our audience.
Thank you all.
Good night.
Thank you
Good
for
night.
listening.